The hallmark of the beginning of perimenopause is less circulating progesterone because your ovaries are getting ready to go into retirement.
So number one, the stressful world rinses progesterone out of the body because it's used as a building block to make anti-stress hormone like cortisol.
Progesterone is directly increasing GABA tone. So when you have more progesterone around, you will sleep better.
There's kind of 3 different types of progesterone is bad, whatever, it doesn't work for me.
It takes more than hormones to fix our hormones.
So it is enormously important, but it got absolutely relegated to the back of the room, being a naughty hormone in the corner with a dunce cap on, like in the olden days, when they really didn't understand why, when they first started using hormones and they used only estrogen, there was an increase in endometrial cancer, or the lining of the uterus, or you could say uterine cancer. And it's because all the hormones need to be dealt with in balance. But if you give estrogen without progesterone, that is the policer or the balancer of estrogen, you can have too much growth because progesterone helps control growth. So when they first saw this happening in the beginning, they knew estrogen made women look younger longer. And there was a gynecologist named Wilson out of England who wrote a book called Feminine Forever. And it was all about the promise of giving women hormones to help them stay younger longer, because we all feel better when we look better. I'm going to be 76 in a few months. And I just came back from California visiting a lot of my old and dearest friends who are in my time range, and I am aging completely differently than they are. And we'll go more into that, but I attribute it, like we just had a conversation, to balanced hormones and healthy living. But it's not like I've had an easy path to get there. But when Wilson came out with his book, everybody got excited that estrogen maybe could slow down the Mack truck of aging. So they gave women estrogen, and estrogen rules collagen of the skin. Skin looks better on women with estrogen. It keeps your bones more healthier, so you stand up straighter. You have estrogen receptors, so when signals go to your lungs and your esophagus and your vocal cords, you could project better. So women on hormones can continue to command in the negotiating boardroom better and longer, or lecture better and longer than women who are not on hormones. But when estrogen is given without progesterone, you can have problems in the uterus. So they then thought if a woman didn't have a uterus, she didn't have to worry about progesterone, because the only action early on from the 1950s and 60s onward was that's all that this little hormone did. It either supported pregnancy in pregnant women, or it protected the uterus from too much growth action of estrogen. They thought that's all it did. But hormones are very misunderstood. And a big reason is that they are the most powerful signaling molecules in the body. And what I mean by that is the body has an internet system. And we all know how important now email is. When you wake up in the morning and open up your computer and you get into your email, you're so excited because you're in touch with people for play and people for business. If your email freezes up, if your Wi-Fi freezes up, you get into a very frantic state because nothing is moving and communication is blocked. So hormones deliver signals, or you can refer to them as emails, to genes to tell cells what to do to keep us healthy. The most powerful compounds we have in the body speak to genes. Whatever can speak to genes rules. The only things that can really actively speak to genes are sex steroid hormones, and then a new exciting famous player that's emerging on the block, vitamin D. We've heard a lot about vitamin D in COVID. We're hearing more and more about it. But why is it so amazing? One, it's a vitamin, which means you can't make it yourself, so you got to take it in on a regular basis. But two, vitamin D can also speak to genes. So we think of our hormones as signaling molecules that run the internet of the body that deliver emails to your cells, and they do it via being able to talk to genes so that your brain keeps thinking, your vocal cords keep vibrating, and you could speak. As you just said, with COVID, they discovered that women on hormone replacement or younger women with more hormones would get COVID more, but they would die from it less. And when they did a deep dive, it's because estrogen and progesterone help protect the immune system. But in particular, progesterone has ways to signal the lungs to keep the lungs safe and to repair the lungs from injury. So they took men in the ICU and they gave them standardized care, or they gave half the men standardized care plus 100 milligrams IM injection BID, which is twice a day of progesterone. And they tracked how long were they in the hospital, what were their complication rates, how did they do. Guys that got progesterone signals that delivered emails to the cells in their lungs got the messages to repair those lungs and not get that ground glass damage that COVID can in some patients do. And they got out of the hospital statistically in shorter periods of time with statistically less complications and the need for less meds. So what we know is that most hormones are made in glands, and then they're squirted out into the water-soluble highways of your biological blood, and then they swim around through your body looking for target tissue. What in the heck is a target tissue? It's tissues with these little satellite dishes waiting for these emails, longing for these emails, hungry for these emails. So wherever there are these receptors, and each hormone has its own receptor, so progesterone will seek out progesterone receptors and signal or deliver emails to those receptors so that the local tissues stay healthy. So we have progesterone receptors in our brain. We don't have them just in our uterus. That's the old saying was, if you don't have a uterus, you don't need progesterone. Thinking its only job description was protecting the uterus against too much or unopposed estrogen. If a doctor tells you that, run, do not walk, what is that old saying on Monopoly? Do not pass go, or whatever that is, pay $200. I don't remember the old saying of Monopoly. A doctor that says you don't need progesterone if you don't have a uterus is so old hat, and it's been old hat for a long time. And unfortunately, it's even being still taught in schools. I know that at National, where I went to naturopathic college for a few years, they were still teaching for 20 years the same exact thing. If you don't have a uterus, you don't need progesterone. So let's look where these little cells, receptors, satellite dishes that want to take messages from hormones. And let's look at progesterone satellite dishes in particular. We have progesterone receptors in our brain. We've got progesterone receptors in the coronary artery of our heart that keeps our artery that can, if it goes into spasm, can kill us, keeps our artery relaxed, and keeps our heart healthy. We have, as I just said, progesterone receptors all throughout the lining of the lungs. We have progesterone receptors in the prostate. We use progesterone in men to treat benign prostatic hypertrophy when the prostate gets too large and they stay up all night urinating and feel really exhausted and cranky all the next day. Wherever there are progesterone satellite dishes, the body wants those emails for the internet system not to freeze up, but there's more. So when progesterone is made, for example, in the adrenal gland, or when you, in the middle of your cycle, you ovulate, but you're not going to be fertilized, the burst corpus luteum makes progesterone. So we make progesterone in the ovary and we make it in the adrenal gland, and then it travels in the bloodstream, looking where the heck to go for these satellite dishes. That's endocrinology. That means a hormone was made in a distant gland and it's going to seek out target tissue, satellite dishes, or the other term in science is receptors. But wait, there's more. We can actually make progesterone all over our body with progesterone producing enzymes. That's called endocrinology. In other words, we make locally. So for example, in the heart, in the brain, let's talk about progesterone in the brain. Progesterone has many progesterone producing enzymes in the brain. There are 6 areas that are known so far, but hormone research is young and it's new, and we're learning new things all the time. 6 areas of the brain have enzymes that locally produce progesterone. They then signal the genes in local satellite receptors, and then they're degraded. So we make progesterone all over the place. We make it in our brain to help us sleep at night, to help us feel calm in the face of a crazy, chaotic world that nobody knows what tomorrow is going to bring. Of course, planet Earth has always been like this. We make progesterone in in areas that are really rare. We make progesterone from swan cells that make the insulation around almost all nerves, the myelin sheath that protects nerves. Progesterone helps your nerves stay healthy. So MS patients that have demyelinating disease, we give them lots and lots of progesterone so that we can help them make more insulation, and we can actually start shrinking some of those white brain lesions that are identifiable on MRIs. So progesterone has many, many hats. The old thinking was it only protected the uterus. So if you didn't have a uterus, what the heck? You didn't need it. And actually, there's still a lot of arrogant docs, not all, that still think that way today. Run, don't walk. This doctor is caught in old thinking, hasn't done any research on their own, and you really don't want to go to them for consultation about your health because they're not up on what they should be, and it's human to be down on what you're not up on. So you often get negative answers from people who aren't informed. So it's very important to realize that, because there's very few docs that have been trained at the moment in hormones.
What is it about our modern day lifestyles that is contributing to progesterone deficiencies? I think this is relevant and timely because there are lifestyle decisions that we sometimes make unknowingly that can drive down progesterone, that can contribute to our progesterone not being optimized before we even get to the point in our lives where we need to be utilizing hormone replacement therapy. I'm talking about younger men, younger women, modern day lifestyle contributory factors that can contribute to this overwhelming deficiency, not to mention some of the endocrine issues like PCOS that can also contribute.
That is a really great question. And by the way, you have a wonderful voice in talking with you. So this is really a lovely experience on body, mind, spirit level. That's a great question. So first of all, we used to think that hormone replacement was mainly for older people, women in perimenopause, but definitely in menopause, and men in andropause. And it was mainly for older people. But this is no longer the case. And that is because our lifestyle and our dirty planet have created a condition where younger and younger people are more and more insufficient in basic hormones. And remember, these hormones run the internet system of your body, so that when they stop working, what are we seeing in young people? We're seeing body dysphoria, gender bending, depression, mushy men, men that look like women, feminized men, masculinized women, and conditions that are emerging that we really haven't seen before, like polycystic ovarian syndrome, which is really like menopause in a younger woman. It's the #1 driving issue of infertility in younger women. And we're all kind of a mess because our hormones are a mess. So what's going on in our lifestyle that might be rinsing out our hormones at a younger stage when we should have more robust hormones? Well, the first thing is that we make our stress hormones out of progesterone. So if we are very stressed and it is a stressful world, so I've been in practice one way or another for 53 years. Oh my God. I feel younger and healthier than I've ever felt in my whole life, most of the time, not 100% of the time, but most of the time. And I really had a lot of illness when I was younger. But when I was first in practice, I don't remember 4 or 5, 6-year-old kids coming in and saying they were stressed out. And now everybody says that they were stressed out. And there's huge articles written about the rapid emergent existence of severe depression and anxiety and many other issues, even bone loss and bone integrity. And they've even done functional MRIs. So areas of the brain that have to do with behavior control and verbality, which are run by hormones, they're shrinking. They're not as large as they used to be, although all of this is fixable because of these conditions that I'm going to address in a few minutes. And one of them is stress. But stress isn't just from feeling like you're stuck in a situation and you have no control. Stress can be a hidden infection, a hidden allergy. Stress could come from many different consequences. But when the physiology is in stress, when you use up your own anti-stress hormone, cortisol, you use up your progesterone to make more cortisol. So as we're under more stress and we don't fix it, take the stressor away or we now give several hundred milligrams of progesterone to young kids with ADHD, with Asperger's syndrome, with lots of issues, because progesterone helps and is needed in many of their young bodies because they're using it up so quickly to make anti-stress hormones. So number one, the stressful world rinses progesterone out of the body because it's used as a building block to make anti-stress hormone like cortisol. The other major reason that's so underappreciated is the role of chemicals in our air, food, and water. It's not just estrogen endocrine disruptors that are an issue, but there are anti-progesterogenic endocrine disruptors. The air and water and food is ubiquitous with them. So I wrote one of the very first books on understanding endocrine disruption. It came out in 2000. It was called Hormone Deception. And based on that book, I was invited to be a distinguished hormone scholar at a estrogen think tank called the Center for Bioenvironmental Research at Tulane and Xavier Universities. And I worked with the scientists who developed this emergent field that hormones are the only signaling molecules that can speak to genes. They run everything from our brain and thinking to our nerve repair and insulation, and even the coronary artery health and our lung health and repair after COVID. But at the same time, they're all under attack by chemicals that are sprayed on our air, food, and water. And many of these chemicals are anti-progestins. They are contributing to infertility. Shanna Swan is a famous PhD scientist who worked with us at Tulane. She's still lecturing in the Netherlands and all over the world about this insidious increase in infertility that's occurring. And a lot of it is because progesterone, as we began this talk, it supports gestation, but this hormone is under attack by progestin endocrine disruptors. So eating organic is a huge deal. And it can seem overwhelming, and with inflationary costs, it can seem a bit daunting and expensive. But only 4 or 5 days of eating organically starts to rinse a huge amount of these chemicals out of your body when they do urine tests and blood tests in families that they get to really eat organically like this. We see nature is very generous, and changes that you make often act fast. But that's one of the deals, is this cocooning of our planet with chemicals, much of it coming from the United States, but then it bioaccumulates, goes up into the atmosphere, causes mini whirlwinds of all kinds of anti-hormone chemicals that circle the planet in mini whirlwinds, so that our garbage ends up 10 years down the road in another country's backyard, and their garbage ends up in our backyard. So we're all spiritually and phenomenally really quite united.
Progesterone is directly increasing GABA tone. So when you have more progesterone around, you will sleep better. If you don't have as much progesterone around, you are not going to sleep as well. That's just how it goes. And you'll actually notice this if you're still having, regular periods. You'll notice at certain parts of the times of the month, you'll sleep better than other times. And this is when you're more progesterone dominant versus when you're more estrogen dominant. So typically, earlier in your cycle, when there's more sort of estrogen predominance, you're going to feel more awake, alert, because estrogen actually has the opposite effect. Estrogen it blocks the GABA receptors. So you feel less tired. Typically, you can go on less sleep overall, and you feel pretty good, especially around ovulation. But when the progesterone starts being more, on the balancing higher than the estrogen, that's when you're going to need more sleep. You're going to feel like you need an extra 30 minutes in bed. You can't get out of the bed in the morning and things. But this is very important during the menopausal time, because this is one of the reasons why women will have a much harder time sleeping. So it's so important to support the GABA system in this capacity, right? I mean, of course, giving progesterone is an option, and that depends on the situation, and of course, what your perspective is on HRT and things like that. But in essence, at least for me personally, I think it's a good idea. But along with a battery of other things. But my overall perspective is certainly HRT is something to think about. But how are we supporting the production of GABA? How are we making sure that you're not depleting it as well? I mean, one of the major things that's depleting it all the time, that all of us kind of know this, intuitively, is stress, right? So if you're always stressed, if you're always, your cortisol, which is like your stress hormone in your body, it's your steroid hormone, cortisol depletes GABA in the system. And so it also depletes some of the cofactors, which are these other things like B6 and magnesium specifically, that are responsible for the conversion of GABA from its precursor. The precursor to GABA in the brain is something called glutamate. Glutamate is our excitatory neurotransmitter. In fact, it is in combination with GABA, the total between the two of them is 80% of your brain's neurotransmission. Okay. So the rest of the other ones, norepinephrine, dopamine, serotonin, only 20% compared to glutamate and GABA. But glutamate, and which is super interesting, is that the way we've evolved is that glutamate is our excitatory neurotransmitter and GABA is our inhibitory, right? And there's always going to need to be a balance between these two. And there has to be conversion of these two from glutamate to GABA. You need B6 and magnesium to do this. So if you're B6 or magnesium deficient, you're going to have a hard time making that conversion. If you're actually not making enough glutamate in the first place, then you're going to obviously have a hard time, making enough GABA. If you're depleting GABA so fast that you're having a hard time making that balance shift fast, then you're going to get a glutamate overabundance. And then what's that going to happen? It's going to be like this, it's like that downward perpetual cycle spiral where you're stressed and then you can't get unstressed and you feel worse because you don't have enough of that, that GABA there, and you have too much glutamate around. I mean, the most common example of this that people kind of know of, that they've had the experience, is that you go to a Chinese restaurant and you have MSG in your food. MSG is monosodium glutamate, and this is a direct source of glutamate to your brain. So this is why you get headaches, you feel irritable, you can't sleep. It's because all of a sudden you have this overabundance of glutamate in the brain. This is happening to all of us on a regular basis just because of anxiety, stress, nutrient depletion. Gut issues can do it too. If you have a leaky gut as well, if your gut's not working very well, the main fuel for the small intestine is something called glutamine, which is an amino acid. And then glutamine is also the precursor to glutamate in the brain. So as you can see, this is all connected, but the key here is to understand that, if you're GABA deficient, we have to support that system.
What are some of your favorite ways to support the GABA system from a lifestyle related measurement?
Lots of different ways that we all can use. The most important ones are find ways to relax. Now, that sounds like a tall tale for a lot of people, but the easiest thing, and I teach my kids this, and it's just learning how to breathe. We all think we know how to breathe because we do it reflexively. But if you learn how to, spend 2 to 5 minutes just prolonging your exhales. And so I teach my kids either like a box breathing technique, or what's even easier for them is the 3-5 technique. So breathing in for 3 seconds, breathing out for 5 seconds for 2 to 5 minutes. Because once you can increase your exhales are going to help you reset your nervous system so that you come out of that fight or flight, you decrease that sympathetic tone. I'm a huge fan of meditation in general, and I don't think that everybody is going to want to meditate. I totally understand that. But even just doing breath practices can be really great. If you're not into just doing that, I have, even some light stretching, or if you're into yoga, like even some just holding some yoga poses for a couple minutes can even isometric kinds of exercise can be really helpful. So like, if you're doing, just a very easy, easy kinds of yoga poses, breath work. Interestingly, on the other side of it, exercise can be very helpful here too. As long as you take time after exercising to like let yourself recover and you don't go like immediately into the day and like all of the crap that you have to do. Like that's like a big thing over the last, 4 or 5 years has been like the Wim Hof breathing, for example. That's not relaxation breathing. Okay. That is sympathetic breathing. Now, can you use that as like your exercise and then, relax afterwards? Absolutely. But you still have to work on your breath practices or do some meditation or some other ways. And so I find that, for me, like the breath practices are pretty easy for my clients and patients to work on. There's other ways that I try to help, with the, resetting the nervous system. There's some, vagal nerve stimulators that I work with people. So like you can work on your vagal nerve, which is in your, a lot of places to get it, but like your neck is easy. One thing you can do, actually, this is kind of fun, is just do some humming or singing. If you like to sing, like that's also a great way to reset your nervous system. So I have my guitar over there. Like sometimes I'll just like, if I'm really kind of like, just been like going, if I can take like 5 minutes and do some humming or something like that, or even blowing into a straw will do it too. If you have a straw and some water, like, when you're a kid, like you're blowing bubbles in the water, that's actually prolonging your exhale. So, so you can do that. I also, if you have kids, you can pretend you're a kid for 5 or 10 minutes. Your kids will love it. And like, you just get into play mode. That's really helpful too. So those are some of the ones that I use. I mean, I have others. I mean, obviously like your diet, your nutrition is really, really big here. Your relationships. If you're sleeping with a partner that's snoring all night, they've done studies that every time your partner snores, your cortisol level goes up just a little bit each time, even if you don't remember waking up. So address that, right? Sleep divorce, it sounds nasty, but if you're sleeping in a separate bed and you're both sleeping better, all the power to you, right? So there's a lot of other things, but these are some of the highlights.
So when you are working with your patients, whether they're male or female, and you are first working on lifestyle, then consideration given to supplementation that can support this system, what are your go-tos, or what are your kind of high-level things that you're considering utilizing?
So yeah, GABA supplements are too big. GABA, the molecule, is too big by itself to get across the blood-brain barrier. So this is a barrier that's evolved to keep things out as much as possible to protect our brain. If we have systemic infections or inflammation, the brain tries to protect itself. The problem with modern world as it is that many of us have leaky brains because we have leaky guts. If our gut is not doing what it's supposed to do, keeping things out, there's a significant amount of inflammation that happens in the system. The immune system starts getting revved up in ways it's not supposed to get revved up. This can lead to things like autoimmunity in some cases. We saw a rash of this, and we're still seeing it a lot now, sort of post-pandemic as well. And so if you take a GABA supplement and it works for you, it's likely because that barrier is not doing what it's supposed to do. So it can be diagnostic in this capacity. So I don't, recommend doing this, but it is a way to say, I need to get some more help with some additional testing and work with a practitioner or do my own, research as to why this may be the case. And so what's interesting about the GABA receptor, though, is that typically, so the GABA A receptor specifically, which is the more common one, it has 5 subunits. And on those subunits are all these binding sites where other things can bind. They can bind and increase the affinity for GABA to bind to where it binds on the receptor, or it can have the opposite effect where it can decrease the amount of GABA that binds to the site of where GABA would bind on the receptor. So these are called allosteric modulators of the GABA receptor. And we already alluded to one earlier when we talked about alcohol. Alcohol, benzodiazepines, these are very commonly used to modulate the GABA receptor on these allosteric sites, increasing the affinity for GABA to bind. But what's the problem with these particular compounds? What happens with alcohol binds very tightly to where it binds on the receptor, increases the affinity for GABA to bind so much that you actually start seeing a depletion of the GABA very quickly. And what also happens is that it unbinds very quickly after it's bound so tightly. This is the common scenario that I'm sure many of your listeners have had, where you drink some alcohol to go to bed, or before you go to bed, you fall asleep very easily, but you're up like 2 hours later and you can't go back to bed. So what just happened? You bound to the receptor very tightly. You depleted a whole bunch of GABA very quickly. You unbound to the receptor. Now you have this glutamate overload compared to GABA. And that's why you feel irritable. You get headaches. I used to get the worst hangovers when I drank alcohol. And it was like 2 or 3 hours after I went to bed, I'd wake up with this like pounding headache. And everybody knows what I'm talking about, unless you have like very significant Irish blood or something like that. Or, you have no, there are those few people out there that don't get hangovers, but in essence, that's what's happening with alcohol. And what's happening with benzodiazepines like Ativan, Xanax, Valium, these bind so tightly to the receptor as well that they cause the same issue over time. And what that issue is what we call tolerance, withdrawal, and significant dependence, right? Because what the GABA receptor will do over time is it will try to protect itself. And it does this by decreasing the number of those receptors and trying to have less capacity for you to bind GABA there, so that, because you're flooding the system with this need for more GABA. And so you're depleting GABA over time. So the system's trying to compensate for itself. So what you really want to do is work with, compounds that don't do this, obviously. And then if you're working with compounds that don't do this, you want to be thinking about this in 2 different ways. The first way is that there's all these other compounds, and we'll talk about some of them, that can bind to the GABA receptor and increase the affinity for GABA to bind. Cool. But they don't bind as strongly. They're much more safe. They've been around for thousands of years. And I'll give you a couple of these in a minute. But the other thing you want to think about, even so, is that if you're giving something that's going to increase the affinity for GABA to bind, you want to make sure you're not depleting GABA in the process, even if these are more natural compounds, because it can still happen. So what are some of these compounds, right? One of the most common ones that, many people have heard of in I think recently as well, is something called kava. Kava is something that's been around for thousands of years. It's been used in the Pacific Islands. It is something that modulates the GABA receptor by binding to one of these allosteric sites. And then it increases the affinity for GABA to bind. So kava is one of them. Another one that I like a lot is something called magnolia bark or hanokiol, which is another one that binds to one of these sites on the other, like on the GABA receptor, but not where GABA would bind. So allosteric, it's called a positive allosteric modulator. There's actually the endocannabinoids, the cannabinoids, the cannabinoids themselves, not endocannabinoids. Those are the ones that are internal. The ones that we take themselves, like CBD, CBG, CBN. These all bind to allosteric sites in the GABA molecule, or GABA receptor, and increase the affinity. Now, interestingly, THC is different. THC actually is a negative allosteric binder. So it binds to the GABA receptor and it prevents GABA from binding. This is why people that use THC, typically, especially in the beginning, will get anxiety, right? You have that, you get that anxiety when you take THC. Interestingly, opioids, things like morphine, heroin, and all the derivatives of those, they actually decrease the sensitivity of that GABA receptor to bind GABA itself. So they actually cause, the issue with the GABA system being more deficient and more issues with the GABA system because of the opioids as well. So there's other things that deplete GABA over time, things like, even caffeine will do it. Even, other stimulants will do it as well. But anyway, so these are all things that are binding, and we can talk about more of those because there's a lot if you're interested, but they're all binding to these allosteric sites. And then there's a couple cool things that can bind to where GABA binds on the receptor. The first one that I love to talk about is something called agarine. Agarine is one of the ingredients or one of the compounds that's found in the Amanita muscaria mushroom. This is a psychedelic mushroom. It's well known across the world, especially for Christmas mythology. So if you're in Europe right now, or especially in Scandinavia, you will find tons of pictures of this mushroom. The mushroom is the red-capped mushroom with white dots. Alice in Wonderland, Mario Brothers, there's a lot of Christmas mythology that's around this mushroom, because if you take this mushroom, you get psychedelic experiences, especially if you take the mushroom that's been detoxified in some way, because it's actually a pretty toxic mushroom. So what they used to do is actually drink reindeer urine. Reindeer love this mushroom, and the shaman would actually collect the urine of the reindeer, drink it, and then have shamanistic experiences in northern in like in the Siberia area, actually. And so anyway, that's a little bit of a side note, but the idea with the mushroom is it has two ingredients, two main compounds. One is called agarine, the other one's called ibotenic acid. Ibotenic acid is the neurotoxic ingredient that causes the psychedelic experiences and also the some of the GI disturbances that can happen with this particular mushroom. Agarine is a long-acting GABA agonist, which means it works on the GABA receptor at the GABA site, binding to where GABA would bind. So that's my favorite one because it's got a great story and it's also long acting. So in some of the products that I use, that we use it for sleep because it's about it stays on the receptor for about 6.5 hours, 7 hours. So it's a great for its half-life. And the other one that I use is something called nicotinyl GABA, vitamin B3, attached to the GABA molecule. And that's vitamin B3 has a receptor that gets across the blood-brain barrier. So you can have B3 and kind of lead the charge through the blood-brain barrier, taking GABA with it. And as a result, you get B3 and GABA in the brain. B3 is mildly activating, which is nice, especially if you want to take some relaxation thing during the day, but not feel too tired. So you have this vitamin B3 attached to the GABA. So GABA binds to where the GABA would bind. So in summing up all of this, I know I spoke for a long time, is that like when I'm thinking about GABA supplementation, I'm thinking about these allosteric sites, these sites on the GABA receptor that can enhance GABA binding, kava, CBD, CBN, CBG, hanakyle, or magnolia bark, along with something that's binding to the site where GABA would bind on the GABA receptor. And that's something like agarine or nicotinyl GABA, vitamin B3 GABA.
This is fascinating. So kind of a big picture to kind of recap some of the things you talked about. If you are taking GABA, assuming that it's working effectively, it probably is a reflection of leaky gut equating with leaky brain. So that explains a lot as someone who has a couple autoimmune conditions and very likely still has persistent leaky gut. Because I was like, GABA works really well for me. Well, that's a tell. Number two, we just did a podcast last month talking about benzodiazepines. And I think about 25 years of being in clinical medicine and, there's a time and a place to utilize them, but I had many patients that were on them long-term, like years and years and years, a lot of my little old ladies that had been on them since the 70s, as an adjunct to help them sleep.
There's little helpers, right? So
exactly.
Yeah.
But alcohol and how it offsets these receptors is GABA receptors. Can we speak to this a little bit? Because I'm thinking about individuals that utilize alcohol either to help with sleep or, kind of generalized anxiety disorder or social awkwardness. I'm speaking about a family member specifically. I think this is where they started utilizing this and how, they utilize the alcohol to be more comfortable socially, but yet ultimately it is unwinding the role of GABA. It's making it harder for GABA to do its job. Is there a threshold with which, the utilization of alcohol can become problematic? I know that there's really become a movement as of, they're calling it sober curious, where it's becoming, people are becoming more curious about not drinking alcohol. But in your clinical experience, when we're speaking specifically to alcohol and its effect on this GABA system, where is the fine line? Like where is, one glass of alcohol may not be problematic, but where is that fine line for you when people are trying to address sleep or trying to support this other side of their autonomic nervous system more proactively?
Yeah, I have a colleague and friend that always says that when somebody asks him if he drinks alcohol, he says there's many more better drugs than alcohol. So why would you still be drinking alcohol? And it really comes down to me when I talk to patients. It's like, well, why are you drinking the alcohol? And trying to understand, like, what's the reason? Is it for sleep? That's just a bad idea.
So what the heck is a leaky gut? So for some reason, God, he or she or whoever, maybe there's another gender to describe God. I don't know. Someone told me the other day there were 9 genders, and I said, I'm confused. Okay, so the gut, for whatever reason, made by our wonderful maker of life, and life is a gift. The gut is only 1 cell thick for whatever reason, just this little gut lining that separates the outside of the world from the inside of us is 1 cell thick. And that one cell is like really important to maintain functionality. If you talk about functional medicine, all functional docs want to make sure your gut lining is functional. And one of the ways it's functional is after you eat, if you have enough digestive players available, you take these large peptides of food, these large chains of proteins and of different types of food. And with a meat cleaver, you cleave, cut to tiny, tiny pieces. And your gut wall opens up a little bit after a meal. And they cross into your bloodstream, go to your liver, and then the rest of your body. And then your gut wall closes. So there's an opening and closing that's optimal right postprandially, which means right the heck after you swallow, you eat. So we have little adhesive proteins. There's families of them. And I won't go into, they're these polysyllabic names like junctional adhesive molecule and occludins and things. There's 44 types of occludins. There's lots of little adhesive proteins. They're so important. They are the proteins that are sticky, and they help when the gut opens after a meal to let the well-digested food through. They then stick back these enterocytes together so that you don't have leaky gut. And what stays in Vegas, what happens in Vegas stays in Vegas. What happens in the gut lumen, the inside of the gut, should stay in the gut lumen. You know, it's kind of a really cool term, but it's accurate. You don't want stuff in the gut that shouldn't be debris that goes in the bloodstream going in the bloodstream. So these adhesive proteins are critically important to gut health, biome health, etc. And what we call the term upregulates or boosts the production and activity of these adhesive proteins are estrogen and progesterone. Who the heck knew that? And that means as you lose your estrogen and progesterone, and as you get into perimenopause, we make a lot of our progesterone from ovulation, and now we're not ovulating regularly, but our enzymes that also intrachronologically produce progesterone all over the place, they're waning because so much of our overall health is waning. We have so many chemicals in our body. When we don't have enough hormone after a meal, when the gut opens, without enough hormone, it can't close back together again. So one of the side effects of insufficient hormones is the propensity for leaky gut. And anybody, if they're a young men now often in their 20s have levels of testosterone that we only saw in old 70, I hate to say old 70-year-old because I don't feel old in my 70s. And most people in their 70s don't have lucidity and speed of processing like my brain does, because your brain is run by hormones and I'm on a fair amount of hormones. And it's very important to know that you can really create a healthier human being if you know how to go about it strategically. But a loss of hormones means the loss of the capability of opening and closing in appropriate timing so that you have more debris going into the bloodstream. And when you have debris going into the bloodstream, your immune system says, holy moly, we're filled with gunk. We better go on overdrive and get this gunk out. And wherever the overdrive tissue is the most focus of it, we name the autoimmune disease based on the tissue that overdrive action. But it's really interesting, the way they treat autoimmune disease is immunosuppressive drugs, because we all know autoimmunity is caused by overdrive of the immune system. So let's shut it down, which of course, these IV infusions and these old meds like methotrexate and so forth, people end up getting cancer 10 years down the road and all kinds of problems because you don't want to turn your immune system totally off. That's absolutely nuts. Not only is that Band-Aid medicine, it's bomb medicine, and it's not good bomb medicine, but we always like to get to root cause. So one of the root causes is not enough hormone. Let's test the hormones and get them back to a better earlier age level. So we've got this open and closing, and then let's check the digestive system, which is a whole nother, conversation. We could go on and on and on. I have a book out, my book, Healthy Digestion in the Natural Way, which was one of the first books on digestion and nutrition and spirituality, was published by Wiley. It sold over 1 million copies, and I haven't finished my textbook that I've been working on for too many years. It's embarrassing, but I'm at page 814. It's a textbook on nutritional gastroenterology. And next year, I hope to put on a course, everything gut, like we did everything hormones this year, because your gut, of course, is the epicenter of your health, but it's ruled by hormones. All along the whole lining of your gut are these satellite dishes for estrogen, progesterone. And we hear that gut immunity is the major place where our immune system works. And that's all run under the auspices of testosterone. So secretory IgA is a licking little protein that licks what comes in from the outside. They lick it. Is this friend or foe? Is this friend or foe? And it's run by testosterone. And that's why there's 159 known autoimmune diseases at the moment. And men get less of all of them, except for the renal one, because they make more testosterone. So people debate, should we give testosterone to older women? Yes, it will help prevent autoimmune disease because it helps them lick, that secretory IgA. And we can measure secretory IgA now and know the licking capacity of how robust is that immunity in functionality in the gut. And it's so great that we can do these deep dives, but patients are so much more complex today to get well because our food, air, and water, and also emotional stress from politics to the pandemic. And is the pandemic real, or was it a scamdemic? And who do we believe? And should you listen to me, or should you listen to some other doctor? Or is there an estrogen window and it's only available for 10 years after the age of 50? And if you're 65 or 70 now, you've missed out. Bunk. We can give hormones till you're in your 90s, even if you've never been on them. And I hope to be the most hormonally balanced corpse or ashes in the cemetery or on the mantle. Hormones can be taken all throughout life to help replenish the internet system and keep your emails going.
Oh, I love the thought process. I will never be able to think of SIGA again without thinking about the licking testosterone. Now, I would be remiss if we didn't touch a little bit on broad strokes labs before we talk about some of the problems that can occur with progesterone replacement, because this is where a lot of the questions came in. So let's look at a cycling woman, days 1 through 14 versus days 15 through 28 versus ideal ranges you like to see in your female patients that are perhaps perimenopause into menopause that are taking hormone replacement therapy that confer the most benefits to their heart, brain, and bodies.
So you mean on all the hormones, or a focus on progesterone? Let's start with progesterone. So I always go to the literature. Not that all the literature can be depended on, because understand that a lot of literature always follow the money, and a lot of science comes from people who are benefiting by that science. And now schools are all given grants by pharmaceutical companies, all of them. The Southwest College of Naturopathic Medicine was just bought up by a lab, big pharma lab. So now they're teaching drugs in naturopathic college, which I think naturopathy was actually the best genre of medicine that we've ever had. And I'm sorry to see that it's not sustaining itself because they want so much to be medical when the medical is not serving us. So it's all crazy because everyone wants status and money and acceptance. So who do you listen to with all of this? So when I was writing Safe Hormones, Smart Women, so I have 21 books out at the moment. And a number of them, though, are out of print because I've been writing books since I was a young woman. And now I'm no longer a young woman in years, but I'm hopefully still a young woman and energetic and an emailing capability. So I had breast cancer 33 years ago. I've been on hormones now for almost 30 years. And I wanted to know if it was safe for me to take hormones. And I had breast cancer because my mother was given the most powerful endocrine disruptor ever invented, diethylstilbestrol. And the majority of those daughters that got first trimester exposures had breast cancer all between the year 44 and 46. Just a huge epidemic of breast cancer in the offspring of DES. They call them DES daughters. And so I wanted to know, is it safe for me to take hormones? Because I lost so many hormones and I went on to have other cancers, and I had to figure out how to stop my cancer madness and be well. And I already was organic and detoxing and doing everything right way before I was getting ill. So it was nothing to do with changing your lifestyle. It was in utero exposure in my mom's womb. So I dove into the literature. And at that time, so that book was published in 2010, and I started doing the research. It took me 6 years to write Hormone Deception because nobody had ever heard of endocrine disruption then. And it took me 3 years to write Safe Hormone Smart Women. And in those 3 years, it was published in 2010. So from 2007 to 2010, in the literature, there were about 100 studies where they looked at preoperative levels of progesterone and women that were going in for breast cancer surgery compared to matched cohorts to women who had breast cancer surgery with lower levels of progesterone, high and low levels they looked at. And then they followed them in many of these studies. It was extraordinary how many studies there were along this line to see who went on to get a recurrence and who went on to live through that recurrence or die from that recurrence. And there was a theme, and it was a very established theme. The women who had the highest level of progesterone close to the luteal phase, which meant that it was between 5 and 6 nanograms per milliliter, those women, compared to women who had follicular levels, which were much lower than that, those women lived longer, had less recurrence, and less death if they had recurrence. Sign me up. That's what I want. We all want to be safe. We all want to be healthy. We all want to be as good as we can be for as long as we can be, right? That's what we're looking at. So now if you look for those studies, the majority of these studies are gone. They're buried. They were in PubMed, but Big Pharma has buried a lot of the old time studies, and it's very hard to find them, but you can find some of them. And I had to go back in through old articles that cited some of these studies to find them. It was really shocking how much, when we Google something online, you don't realize how much Big Pharma has bought the first 100 pages of that Google search. So if you go to Mr. Google, Dr. Google, it's very hard to get an accurate answer. But there was lots of research on this. Carol and I were talking about this in Everything Hormones. She's the main pharmacist at Women's Health International, which is one of the major women's compounding pharmacies in Wisconsin. So we know that the more progesterone you have in your bloodstream, the better breast protection you have. And we want that. And we don't mean you should have excessive levels, but the levels should be somewhere between 5 nanograms per milliliter. And then if you have a history of glandular disease like chronic cystic mastitis, chronic lumpy, bumpy breast, you had a biopsy and you had dysplastic cells, you had breast cancer. If you had endometriosis, if you had PCOS, if you had adenomyosis, you need a lot of progesterone because there's a condition called progesterone resistance where you take in progesterone, but it can't signal. And a lot of these diseases are actually caused by progesterone resistance. And the way you overcome it is by giving more progesterone. So I like keeping women with those histories. So I like keeping my own personal level of progesterone around 20 nanograms per milliliter because I had all the DES daughters exposed in utero first trimester had adenomyosis, endometriosis, breast cancer, and a variety of other issues. And now the granddaughters, several granddaughters have had ovarian cancer at 8 years old. I mean, all these issues are transgenerational. They're passed on even if the exposures don't continue, but we now know the exposures are enhancing. So I translated that science into levels I like to see. I hope this wasn't too long to get to the answer for you. I hope I'm not being too circuitous. I like to see women at least at 5 nanograms per milliliter. And you should be, if you're using topical, you should apply it like an hour before the test and then take the test within an hour that you get whichever. And I use serum now. I've gone through every reiteration. I've done 24-hour urines. I've done I've done salivary. At the moment, what we taught in Everything Hormones was serum and serum interpretation. And I think you can do a real lot with blood. And even if you do use urine like Dutch test, you still have to follow follicle stimulating hormone and sex hormone binding globulin and things like that in the blood. So you cannot get away from needing blood tests added to whatever way you're assessing your hormones. You got to do some serum, which is blood testing. So that's a great way to understand how much protection the progesterone is giving to the body, enough to the uterus, to the breast, but also you make it remember the brain and all your insulation for your nerves and also the repair of your lungs. Why do old people, I hate that term, why do old people get more pneumonia because they have less progesterone. Progesterone protects the lungs from the first assault, and then it helps them repair from that assault. We saw that in the Mount Sinai COVID studies. So we even use progesterone now in men. We don't deny men progesterone because they need it, just not in the same doses, but some men need similar doses to what the women get. And it used to be thought, according to the work of John Lee, who's kind of considered the father of progesterone. I had the honor of lecturing with him and David Zava that runs ZRT Saliva Labs. We lectured to 6,000 people in a football stadium in Arizona. It was like a crazy day, all day long. And he went on to help write one of the introductions for me to hormone deception. He was a lovely man and unfortunately died from an accident. It was a big loss. But he said that a premenopausal woman only makes about 20 milligrams a day of progesterone. So we thought you don't need very much progesterone to achieve protection. And that has since been found not to be true at all. He was the father of progesterone, but he didn't have his dosing right. Nobody's got everything right. And that was one of the things in his beautiful, incredible brain of so much gifts that he gave us. The dosing wasn't one of the gifts that he gave us, and it took us on the wrong path. And also, some people say that you only make progesterone the second half of the month. So you only need to replace it, especially if you're looking at hormone replacement as you age, the second half of the month. No, no, no. You've just learned that your adrenal glands make progesterone the first 2 weeks of the month. It's your corpus luteum that makes it the second 2 weeks. And you have enzymes all over the body that aren't going to be making it as you age, but you can still replace them in the body to the level they should have been so the tissues all don't lose out. Your brain doesn't lose out. Your vocal cords don't lose out. Your lungs don't lose out. So progesterone should be robust and much more robust. We used to think the average dosing of progesterone was 20 to 50 milligrams a day based on John Lee's work. And I hope I get to meet him up in heaven again. And now we think the dose range is anywhere from 50 milligrams to 2,500 milligrams. We now know that progesterone should be the largest amount of hormone in your body of any other hormone in your body. We used to think it was testosterone in women. So if you look at the physiology, you often can understand what dosing and levels should be. So is that helpful for that?
That is really
Okay.
helpful, because inevitably there'll be questions about what should it be. And just lastly, because I want to be very mindful of your time, when we talk about progesterone resistance, and this is women that will tell me it doesn't matter whether they take 50 milligrams, 100 milligrams, I'm very sleepy, I don't feel well, even if they take it at night. I know in some of your other work, you've talked about the role of oxytocin, which is a very important hormone. When you're working with women that you've identified that they have some degree of progesterone resistance, when is oxytocin utilization something that you're considering prior to restarting progesterone?
What a great question. So my next book that I'm almost done with is Oxytocin, and I've been threatening to publish it soon, but I was onxing over the name, but it's almost done. So when the corpus luteum makes progesterone, it makes oxytocin at the same time. So they're closely intertwined, and progesterone is the hormone, as we started this talk, of pregnancy, and oxytocin then squeezes the uterus to propel the baby out. It's a contractile hormone, and it also squeezes the breast to let the milk down. So, but it does many, many, many other things, like your whole entire pancreas and all your islet cells are covered with oxytocin receptors. Your whole digestive tract is covered with oxytocin receptors. So oxytocin has many, many hats that very few people understand. We just think of it as a pregnancy hormone or an orgasm hormone because it's a bonding hormone, and women make more oxytocin if they orgasm with someone they care about and love, not if friends with benefits or masturbation, but you make more of it when you're really with somebody you have emotionality with. So women have a harder time with friends with benefits because they make more oxytocin. And even though the guy says, look, we're just friends, I'm in an ethical, non-monogamous relationship, so just keep that straight, man, woman. And then the woman gets attached because she makes more oxytocin. But progesterone is the most, you can be allergic or reactive is the more accurate term to anything. You could be reactive to peanuts and dairy, and people know about that, but you can be reactive to hormones. And progesterone is the most reactive hormone there is, and I don't know why that is. But if you go into PubMed, which is a free service put on by our NIH, the National Institute of Health, every person can go in there and search all the peer review abstracts, and some of them give you the whole articles for free. So anytime, you should do that more than Google, but know that a lot of peer review is still bought and sold by Big Pharma too. But if you put in progesterone, go to pubmed.gov, P-U-B, med, med.gov, and put in progesterone and allergy and click search. And 65 articles on progesterone-induced autoimmune dermatitis pop up, because progesterone, and there's no other hormone that has that allergic profile and published peer-reviewed data that progesterone has. Now, why that's the case, I don't know, and I'm hoping to figure that out before my expiration date.
The hallmark of the beginning of perimenopause is less circulating progesterone because your ovaries are getting ready to go into retirement. Remember, I just talked about the eggs. Our egg reserve just starts to precipitate and drop off. So when we talk about progesterone therapy, for some women, they really need progesterone therapy 2 weeks of their cycle. Some women need it 1 week of their cycle. The farther you get into perimenopause, you may need it throughout your cycle. Obviously, women in menopause benefit from taking it typically 6 days a week or having 3 to 4 days off a month, however you want to make that work. And that's to keep the receptors kind of sharp. But I would say that, starting with the cheap stuff, the micronized progesterone made with peanut oil, that is very inexpensive. It is immediate release. For a lot of people, that works just fine. For a lot of others, they need compounded progesterone that has sustained release, so that it's a longer acting medication, and that is compounded in a pharmacy. Usually the dosing patterns are anywhere from 50 milligrams to 200. There's someone in my Facebook group that was saying they were on 600 milligrams of progesterone. I'm not sure I've ever seen that. Having said that, everyone's an individual. Dr. Lindsey Berkson talks a lot about progesterone. She's actually a fan of progesterone, both intravaginally, so placed inside the vagina, as well as oral progesterone. Really depends on the individual. Jody asked, as a healthy, fit woman at 72, can I take HRT if I've never taken them in earlier years? Risks and benefits. Jody, this is a great question. And what I would say to you is it depends. Can you start vaginal estrogen anytime? Yes, because it is localized to the vagina. So if you're having a lot of genitourinary symptoms, chronic UTIs, friable skin, pelvic floor issue problems, incontinence, vaginal estrogen, you can start at any point. The other issue is, how many years have you been into menopause? And I actually had a discovery call today and we talked about this. There's this opportune time to initiate hormone replacement therapy. And that has a lot to do with what starts to change internally in the blood vessels, the endothelium, which is this lining of our blood vessels. We know with less and less estrogen circulating that there's more and more inflammation, oxidative stress. And so it has to be very much a conversation about risk benefits. I think that, even if you're healthy at 72, you probably have had 20 years of no exposure to estrogen. And so you really have to do a very thorough cardiovascular workup. You really have to look closely at labs. You have to have a conversation with a provider that's willing to have that conversation. I think the longer you are in menopause, like when you get over 10 plus years, I think a lot of providers get a little hesitant. I can tell you that a lot of my colleagues, and I believe this fervently, vaginal estrogen, you can start that at 90. I mean, if you're having those symptoms of genitourinary symptoms of menopause, I think that we have an obligation to offer that to women because it stays localized. It's not a systemically absorbed drug, or if it is, it's very, very minimal. But my statement to you, Jody, would be, we would have to find a provider that would be comfortable having that conversation and also doing a very thorough cardiovascular workup to make sure there's no plaquing. We know that timing hypothesis is one that a lot of people embrace, that there's an optimal time. A lot of us will say it's the first 5 years into menopause or starting prior to menopause, maybe up to the 10 years. I've had women in programs that have been told, you're over the age of 60. I'm not willing to give you hormones, which I think is ridiculous. There's a lot of very healthy people, but they have to be able to provide some degree of risk assessment. And that's where a very talented, competent, conscientious provider could help you with that. The question is finding that person in your area. Okay. Jess said, I love your mission so much. I'm 40. I have estrogen dominant symptoms, which means I have extremely dense sore breasts before my period. My Dutch test, which is generally a urine and saliva test from a few years ago, showed that my estrogen was going down an unfavorable pathway. She mentions my liver doesn't clear toxins or estrogen well. She has a family history of breast cancer. Could she still benefit from HRT? Okay. Just because your family member, your aunt, died of breast cancer that is not a contraindication to taking hormone replacement therapy. I'm going to say this again. Just because your first degree relative or second degree relative, that's a second degree relative, died of breast cancer, that's not a contraindication. This is where having a really good discussion and having a really good history with your provider is going to help illuminate what you need to be focused on. I just interviewed Dr. Corinne Men. She is a breast cancer survivor. She was diagnosed at 28. She is counseling women on an almost daily basis about the cost benefits. She is a breast cancer survivor and she is now on hormone replacement therapy. So you really have to work with someone that understands the risks, like not just the relative risks, the absolute risks, and can properly counsel you. Jess also mentions my progesterone is almost non-existent on my recent labs, which is common in perimenopause. When I added over-the-counter progesterone cream, I felt more moody, hot flashes, and worse insomnia. Okay, I'm not a fan of progesterone creams. I think that if you are taking progesterone for the purposes of replacing hormones, orally is going to be superior to something transdermal. If you are in menopause, the only option is oral. If you are in perimenopause, you might be able to get away, at least initially, maybe with some cream. But if it's over the counter, we don't know. I mean, there's so many variables that can impact how it's absorbed, what formulation it is. Yeah, and especially, I think that this is where working with someone that is experienced and can walk you through the benefits of oral, even if it's just for a week or two out of the month. I think given the degree of high estrogen dominant symptoms you're experiencing based on what you said here, you may really benefit from oral progesterone therapy, but discuss that with your provider to see what they think. Liz says, if menopausal and on HRT, what are the optimal estrogen and progesterone blood levels to help protect brain, bone, and heart health? This is a great question. And I'm going to go back to saying there are some providers that treat based on symptoms. There are some providers who like to look at labs. I can tell you that it is it's like the wild, wild west right now. There are certain camps that people as clinicians kind of fall into. I think it is much more important that we are monitoring your symptoms. So if your symptoms are quiet, does that mean that we should bump up your estrogen? Possibly. But I think there's a lot that remains to be seen. You'll see some numbers for for bone and heart health, greater than 50 milligrams per deciliter. Some people don't tolerate that much estrogen. Number one, I see other clinicians that are using oral estrogen, which I know depending on the researcher that you follow, some researchers feel like that's the best form of estrogen to protect your heart. We can't right now measure brain estrogen levels. Dr. Lisa Mosconi and I kind of talked around this. She's doing research in this area. I'm actually part of her research study, so I do plan on asking her more about this. But I think that the question is, I think it's more important to be on some hormone replacement therapy than get obsessive about what those certain values should be. I can tell you with testosterone that a lot of providers get funny when women have, depending on whether it's a lab or Quest, LabCorp or Quest, you can have free testosterone levels anywhere from 6 to 8 to 10 milligrams per deciliter, and that's where they like those numbers to be. I think people get a little more antsy around testosterone, although I think that's silly. If you're on pellet therapy, you know that you're not going to have a therapeutic number. You're going to have supra therapeutic numbers just by virtue of the pellet, as opposed to transdermal applications, oral applications of drugs. So Liz, not to not answer your question, what I can tell you is there's a lot of there's a lack of consensus. And I think providers are really, for the most part, focused on symptom reduction and symptom amelioration, meaning getting rid of the symptoms, than they are on driving it towards a number, an empiric number. I can tell you personally that, there's a ratio that we want to see ideally with progesterone and estrogen, and that can get a little bit of a sticky wicket in terms of depending on who you're talking to. So I will just leave it at that and tell you that I've had many providers on the podcast, and their opinions on this are very variable. Cavs says, I am 45 years old and I have trouble with sleep only during the luteal phase of my cycle. Anything to help with this other than HRT? I would say, lifestyle. So if you know that your progesterone levels are low in perimenopause, to me, it makes sense to give progesterone. Call me crazy. I don't think there's no other supplement that's going to mimic what progesterone does in the body. And one of the things that progesterone does is it upregulates a particular calming neurotransmitter called GABA. So I would say during the luteal phase of your cycle, take some oral progesterone, call it a day. The lifestyle stuff is important. Some people do better increasing their either high quality carbohydrates. Some people do better with, restorative yoga and less intense exercise. I think that a lot of it has to do with you as an individual, but oral progesterone, call it a day, make it easy. Alicia said, I'm 49 with regular cycles, but I'm experiencing increasing perimenopause symptoms, heavy periods, increased PMS, irritability, and sensitivity. I got a prescription for 100 milligrams of oral progesterone to take the second half of my cycle. When I've tried it, it seems to give me a lot of bloating and just not quite feeling right. I'm not sure if I should continue to take it and see if I adjust it, or maybe I'm just not in need of this hormone yet. At 49, you are in perimenopause. It may be that you need a lower dose. It could very well be. I have some people that are on 50 milligrams. It could be that, you just find it sedating. Some people need to take it earlier in the evening. I would say, talk to your provider that wrote the prescription if taking 50 milligrams might be something worth considering. The fact that you're getting increasing symptoms tells me that you definitely have lowered levels of progesterone. That's what's driving the heavy cycles, the more PMS, the irritability. For a lot of people, they've gotten so accustomed to having low progesterone levels for such a long period of time that when they start kind of adding in a little bit of progesterone therapy, sometimes it can be too much too quickly. And so maybe backing down on the dose might give you some improvement. But again, talk to your prescribing provider. This is just a first initial C. Good morning. I have the Mirena IUD and was put on 100 milligrams of progesterone daily. So the Mirena IUD is synthetic progestin IUD. So it's secreting some synthetic progesterone, and said I'm put on oral progesterone as well. Was wondering why they told me not to cycle it just the last 2 weeks of my cycle. I'm not sure I know what the question is. Wondering why they told me not to cycle it just the last 2 weeks of my cycle. So probably because in the luteal phase of your menstrual cycle, that's when progesterone used to predominate, and now there's less circulating progesterone. So some people do fine with both. I have some older patients that they have a progestin IUD put in because they don't want to deal with taking progesterone. And they're using it to protect the uterus. So I think that there's a degree of experimentation. And yes, typically when you start taking oral progesterone, it's usually the week before or 2 weeks before your menstrual cycle starts. If you even get a cycle, and if you've got an IUD in, you may not be getting a cycle at all. Okay.
So of those people, there's kind of 3 different types of progesterone is bad, whatever, it doesn't work for me. One type is called intolerance. And that is kind of basically just means that you are more sensitive to it than other people. So you have the same kinds of things, instead of, it can help you sleep, but then you sleep too long, and it can calm you down, but then your mood is too calm, you're too flat, you're depressed. So it's the same symptoms as regular progesterone, but people are very sensitive to it. And then the second type is called paradoxical progesterone response. And that is essentially when one of the metabolites of progesterone called allopregnenolone, it goes to your brain and binds to your GABA receptor. And in most people, that causes this relaxation, this inhibition of the brain. In some people, though, that GABA receptor is like configured differently. And so that binding actually causes excitation. So it makes them wound up and they can't sleep and they're, anxious and irritable. And so that's the second type. And that is also pretty common. Those first two are both pretty common. The third type is a hypersensitivity, which is actually an allergic reaction. It's an IgE mediated allergic reaction. So it's an actual allergy, rash, hives, bronchospasms, swelling of the face. Very rare, less than 1% of people, but more serious also.
Yeah, it's really interesting because I feel like for every 20 of us that are rave about progesterone and you're never going to have, you're never going to stop taking progesterone because you feel the benefits. There are a few people that will say, I get, and what I typically hear from people is not so much that they feel like, they can't wake up or they feel depressed. It's that they feel stimulated, so they get this glutamate receptor stimulation as opposed to GABA. And so all of a sudden they're like the opposite. They're not falling asleep. They're totally irritable. And so for those that suspect they may be on this spectrum, what are some of the things that they can do? Now, you talk about this in particular in your Substack article, which again, excellent, must go subscribe to it. What are the options for people that feel like they get this magnification of symptoms? What are some of the options that they can do that still protect the uterus because there are concerns around there?
Yeah.
What are some of the other options they have for treatment?
So the probably the easiest option is just to change forms. So instead of doing oral, like instead of doing a pill, which is going to get metabolized heavily into that allopregnanolone, change it out for like a vaginal progesterone or even a rectal progesterone, or even a troche, like underneath the tongue. So anything that's not a pill going into your stomach and then into your liver is going to create much less of that allopregnanolone. And so that is going to be much less excitatory, essentially, to your brain. So the other option, second option, is to actually either increase or decrease your progesterone dose if taking it orally. Because it turns out when it comes to the paradoxical response, there's this like sweet spot in the middle of like serum allopregnanolone level that causes disturbance. And if you're higher than that or lower than that, then it actually doesn't cause the same disturbance, which is kind of weird.
It is. It's bizarre. So for listeners' benefit, like typical oral progesterone route of administration is oral, dosing somewhere between 50 to 200 milligrams, depending on the individual. When you're talking about those that have this paradoxical response, are we talking about doses of like 400 milligrams, or are we talking about teeny tiny, like the range of doses, teeny tiny, like 25 milligrams? Is that typically what you're thinking?
Usually the worst doses for those people are between 1 and 200 milligrams orally. And then again, everyone's different, but if you could go lower than that, like if you're, 50, unfortunately doesn't offer uterine protection at 50 a day. But if you're taking some other kind of progesterone also, then 50 is usually okay. And if you go up near like 400, then that's also usually okay. But everyone's a little different, but that's kind of the range that most people, the worst range for them is the one that we give them, which is the 1 to 200 milligrams.
And if you're changing the route, so if someone's taking intravaginally, intrarectally, sorry, I don't know the answer to this question. Does the dosage also correspondingly change? Because I would imagine like rectal absorption is very different than intravaginal absorption, I would imagine.
Yeah. Well, so most of the studies that we have are in vaginal. We don't have a lot of studies, at least in the hormone space. We have some in the fertility field, but most of our kind of HRT studies are looking at vaginal progesterone. And the uterus the progesterone goes into the uterus first, which is great because it's a uterus first pass effect. And so the uterus gets, up to 10 times the concentration that it would like if you were taking it orally. So in theory, you could go with a lower dose. You could, if you take 200 orally, you could probably take 100 or even less vaginally. But the British Medical Society guidelines on this from 2022 are just take the same dose both ways. So it's super simple. And, what's kind of a cool trick is you can actually take your oral micronized progesterone gel caps, the one like the Prometrium. You could take that vaginally. And then you could also take it instead, if it was easier, you could do it rectally. That's just not as well studied, but from what we can tell, it's similar.
Yeah, it makes sense. And from years and years ago, when I went through infertility treatments, I actually took intravaginal progesterone for the duration of my first trimester.
Mm.
And I remember what the irony is, I recall it made, well, it could have been a multiplicity of things. You could be pregnant and bloated. But I remember thinking, like, when I started taking oral progesterone as a perimenopausal female, I was like, oh my God, I hope the bloating that I experienced years ago, it has not been problematic. So I'm happy to
Yeah.
report that that was not an issue, but that's actually what my reproductive endocrinologist recommended, was to take it intravaginally, obviously for a different purpose,
Yeah.
but good absorption there as well. Now, so that's progesterone. And you've done, again, such a good job talking about the value of estrogen, as a longevity drug. I think that there's a lot of focus on, evolving research, things that we can do to slow ovarian senescence, ovarian aging. But in terms of longevity drugs, estrogen is really important here. And I'm so glad that the pendulum is swinging back to where we're having these conversations, because only 4% of women right now, at least that we can grab the data on, are actually on hormone replacement therapy.
A lot of the doctors in like at Humanot, my kind of co-doctor who does a lot of like deep functional medicine, he definitely uses a lot of those tests. And I think that, I don't think that necessarily everyone needs every functional medicine test. I do think that
Agreed.
we go overboard. And I think that unfortunately that makes this kind of care a little bit inaccessible to some people, because they're, if you have to order $3,000 of tests to even get started with a patient, then that's a pretty high, bar for most people. But I do think that there are special patient populations where, more detailed testing is definitely beneficial, whether it's things like that, where you're looking at micronutrients or, heavy metal testing, or, all the things. Like, there's a place for all of it, I think.
Yeah, it's interesting because one of the things that has stood out to me, and I don't order that test all that often, but if I have someone that's got autoimmunity, we know they've already got leaky gut, they're starting to have this constellation of like hair growth issues, thyroid issues. It's like, okay, what are some, like, no, it's not an inexpensive test, but can it yield good information that ultimately will help us fine tune, like, what vitamins or minerals do you actually really need? And then
Yeah.
kind of going from there. Like, I cannot tell you how many people I've worked with who have omega-3 fatty acid deficiencies. Probably not surprising given the fact that we have so much inflammatory
Yeah.
oils in our diets, but just these kind of relative imbalances of fatty acids that can really exacerbate like skin issues, hair issues, can really be, surprisingly problematic. What are your thoughts on progesterone's role in hair pause? I'll give it I will give you attribution for the hair pause, but how does progesterone help protect the hair follicle?
Progesterone is a weak 5-alpha reductase inhibitor. So it weakly blocks the conversion of testosterone to dihydrotestosterone. And certainly, medications that are used in men like Propecia or finasteride, which is a very strong blocker, those medications work really well for men's hair loss. I mean, they have problems, but they do work well for hair loss. So progesterone has some of that weak activity, where it's a little unclear what else progesterone is doing in the hair for the hair follicle. Estrogen is pretty strong. Like, we know estrogen is very important for the hair follicle. Progesterone, we're not quite sure about, and we're also not quite sure about, DHT and androgens. If anything, they're probably not great, but even that evidence is a little bit confusing.
Yeah, no, certainly helpful to have that. And when you're talking about lab work that you think is beneficial to evaluate hair loss, I think a lot of people just automatically jump to sex hormones, but you do a really nice job in that Substack talking about, like, these are accessible labs for everyone. These are not unusual labs. These are not functional integrative medicine labs. What are some of the labs that you think are important to do to evaluate hair loss issues?
I mean, some of the key labs are thyroid, and including, obviously all that, like TSH, free T3, free T4 at the minimum, like at least get those three, and making sure that you're in that kind of sweet spots, hopefully kind of towards the upper end on the T3 and T4 of the reference range versus the lower end. And that can make a big difference. And then ferritin is also another really important lab to get. A lot of women, when you're menstruating, you're losing blood every month, and that, of course, you're losing iron, and ferritin is just the stored iron form. And there's a number of good studies that show that you want to have a ferritin of at least 50 to 80-ish for hair, for good quality hair in women, and that in men as well. But a lot of women, their ferritin is like 20, but no one's checking it because it's not like on you're not anemic, like, your hemoglobin, hematocrit are normal on like the basic test your doctor does. And unless you do just add on a ferritin test, no one you don't know about it. So that's another big one, and easily, pretty easily treated with just high iron foods and supplements if needed. So those are two. Certainly the hormones, that all the hormones we talked about, estrogen, testosterone, those kinds of things. And then sometimes I don't tend to check all the micronutrients, but you can check like B vitamins. You can check selenium and cadmium if you have specialized tests for those. I do like omega-3 fatty acids also from that and that. And then also just like general inflammation markers, getting a CRP or some sort of test. And I think it's important to do anyway. CRP, blood sugar test. Like, we know that any metabolic diseases of all, any kind of inflammation that's bad for your body is also bad for your hair. So you got to kind of think about those things too.
Well, I think a lot of people don't realize, like, if you're chronically stressed, if you go through a stressful period, like when I spent 13 days in the hospital in 2019, I had so much hair loss after losing 15 pounds that I didn't need or want to lose, that I remember my hair person was like, you may need to think about extensions. And I was like, absolutely not, because that will then become another long-term thing. But chronic cortisol elevation
Yes.
Can actually impact the hair follicle quite significantly.
Yeah, absolutely. Whether it's physical stress, like you're sick, or emotional stress, mental stress, anything that's causing that cortisol to be up over time. And the thing is, the hair loss usually starts like 3 to 6 months after the stress. So it's not like you're stressed out and your hair starts falling out. It's that, it starts 6 months later and you're just like, what is going, like it kind of comes out of nowhere. And so it's difficult to pin down sometimes what's causing the hair loss, because it's, who knows what was happening 6 months ago. And it's also similarly, when you get to, treating it, it usually takes 3 to 6 months before you start to see benefits also. So it's very difficult, because who wants to be on a medication or whatever for 6 months and not know if it's even working or not?
Yeah, that can be super frustrating. I'd love to end the conversation today talking about things that you feel like are overrated or even ineffective in the longevity space. And by this, I mean things that you kind of, because you understand the science at such a deep level, you kind of look at it and say, okay, well, there's it could be one of those like pop-up IV places that's administering things that are ineffective. You can't actually absorb them, or, these detox teas, or, professionals that are still prescribing oral contraceptives as HRT, which is not HRT.
Oh, yes. Well, all of those things that you just said, I don't think that detox teas, pills, there is a way to detox your body, but I do think you have to be very strategic with the provider who knows what they're doing to really do that properly.
Next question is from Anonymous. I've heard you talk about oral forms of bioidentical hormones like progesterone and estradiol, but what about other routes? As I'm in perimenopause, should I use oral or another form? Well, Anonymous, I think so much of it's dependent on where are you in your perimenopause journey? What are your symptoms? How is your sleep? How are you managing your stress? I think in many situations, I think oral progesterone, even if it's used just during your luteal phase of your menstrual cycle, can be a really very effective way of helping support sleep, anxiety, depression, etc. Now, obviously, there are women that benefit from starting even estradiol therapy or an estrogen patch during perimenopause. And I've heard Dr. Peter Attia mention more than once that he actually likes to start women on HRT in perimenopause and not wait till they're in menopause, which I think is completely reasonable. So I think it's dependent on your hormones, your symptoms. I do not like oral estrogen. I do not recommend anyone take oral estrogen. It gets a very large first pass effect. It magnifies all the side effects. I think that starting with oral, compounded, or generic progesterone, obviously the generic progesterone is the least expensive option, super inexpensive, like $6 to $9. I recall when I was filling mine, very inexpensive. If that doesn't work effectively, you can move on to a compounded option, which usually has sustained and immediate release. And some people need that. And then thinking about estrogen, I think about estrogen patches, very inexpensive. It's usually E2 or estradiol, which is the predominant form of estrogen. And then sometimes providers like to use a combination of estradiol and estriol, which is E3. That can be breast protective. Sometimes you'll hear that described as biased, but I do think that there are very inexpensive options that are available that you can fill at your local pharmacy without a compounding pharmacy. And if they work well for you, awesome. Like, awesome. Now, testosterone. It's important to talk about testosterone. Testosterone, there is no FDA approved form of testosterone for women, which is criminal. So some providers will give women a tenth of the dose of a male dose. So men have these androgel packets, and they're not very big. I think trying to give someone a tenth of a dose is really hard. You probably get too much one day and not enough another. So more often than not, what you see is compounded testosterone for women, either in perimenopause or menopause. Now, not every woman navigating that transitional period needs testosterone. About 25% of women still make enough testosterone on their own. And I actually listened to a lecture by Dr. Pam Smith, and she was saying, I'm one of those people. I actually have very healthy, robust testosterone levels. I'm not one of those people. So I actually really benefit from testosterone, compounded testosterone, because for me, it's a big differentiator for, I know everyone always focuses on libido, but I think about motivation, a desire to, go to the gym, muscle building, which for me is the predominant reason why I take it, because I think it makes a big difference for me. I will never be super ripped. I'm never going to be one of those women, like those kind of mesomorph bodies where they're super ripped. That's just not my body phenotype. I'm just kind of thin and lean. So for me, it's about allowing me to have the opportunity to build that. So getting back to Anonymous's question, a lot of it depends on symptoms and testing. I think this is a really good indication for working with someone that is savvy with being able to support women at the stage of life you're in. Sometimes people will also make recommendations about DHEA, sometimes pregnenolone. Pregnenolone is known as this memory hormone. Those things are over the counter, but I don't generally recommend them unless you are low or deficient. And then obviously, looking at other hormones, I think can be helpful. Full thyroid panel, looking at cortisol, looking at all those things can be helpful for providing a total clinical picture. Okay. Next question is from Erica. A friend of mine just started taking pellets and recommended them to our friend group that others should start them too. We are all in our late 30s, early 40s. I don't agree with this because I've heard mostly negative things about pellets, but wanted to hear your thoughts. Erica, it has been my experience clinically. I have never received pellet therapy, so I want to be totally upfront about that. I think there are some very well-meaning people that are using pellets and have had good results. I think they're pretty conservative. But what I've also seen is a lot of anti-aging clinics and pill mills is usually what some of us will call them, where everyone's getting pellets and, people feel really good initially, and then it's just not consistent. And there are probably listeners to this podcast that have had great experiences. And if you are one of them, that is great. I typically see the people who've had a negative pellet experience. And in talking to colleagues of mine, many of whom have been guests on the podcast, we almost always have conversations around this topic. I think judiciously in the hands of a very competent, capable, conscientious provider, I'm sure there is some efficacy for pellets. But again, I usually see the people who felt great when they first got pellets and then they feel terrible. I've had women come to me in programs that have said, I know my testosterone's low. I have no energy. And then we look at testing and their testosterone is actually in a very healthy range. And that's not the issue for why they're tired. So I think on a lot of different levels, we have to think about like why in a younger woman. So if you're not menopausal, if your testosterone is low, is it because you're insulin resistant? Is it because of estrogen mimicking chemicals? Is it because of chronic stress? I think those things are important to look at before consideration of hormonal replacement therapy in an otherwise healthy individual. And then I think if it's something you're not comfortable with, Erica, I think it's not the right decision for you. And there's so many other options. I do think that there is a place for HRT used judiciously and appropriately. But I think we have a whole generation of individuals that are just not sleeping. They're not managing their stress. They don't eat a healthy diet. They overexercise or don't exercise at all. They're over fasting or eating constantly. And so I think the lifestyle piece has to be kind of dialed in before we start doling out medications if it's something that would otherwise be fixed with lifestyle. So hopefully that helps. But I would say trust how you feel intrinsically. If you feel that pellets are not the right answer for you, that is totally okay. And for everyone listening, we do have a free guide that we will make sure we link up, that if people want to get access to a list of vetted professionals. When I say vetted, these are people that I know socially. I have not per se gone and seen every one of them as a clinician or as a patient, but individuals, both physicians, nurse practitioners, midwives, PAs that are in the United States that offer hormone replacement therapy, probably different modalities, but we'll give you some other options. Okay. Next question is from Heather. I have had a complete hysterectomy when I was 54 years old, and I'm now 62. So Heather is 8 years into menopause. I was on estradiol. I was placed on estradiol 18 months ago, which has greatly reduced my hot flashes. Is there any benefit at all to also taking progesterone? So Heather has had a total hysterectomy. They took her ovaries and her uterus and her cervix, and she's asking if there's benefit from taking progesterone. And my answer is always yes. I think that there is so much benefit from progesterone. And I recently stumbled upon a researcher, for anyone that wants to go down and read more about this. Her name is Dr. Geraldine Pryor. She oversees the Center for Menstrual Cycle and Ovulation Research, or called CEMCOR. And she talks about how, and she's on the forefront of progesterone research. She talks about that progesterone decreases hot flashes and night sweats and improves sleep. And there's good evidence that progesterone also increases bone formation. So it's not just estrogen that can be helpful. You know, for the sleep, I always say progesterone is great for inducing sleep. Estrogen is oftentimes great for keeping us asleep. Same thing with bones. It's not just about estrogen. We also know we have progesterone receptors and testosterone receptors diffusely across the body. We know that progesterone can be taken by itself. And kind of the conventional wisdom for a long time has been, if you are without a uterus, you don't need progesterone. And I always say the same thing. We have progesterone receptors diffusely around across our body. And so for that reason, and especially for the sleep support, for a lot of people who still feel like a little anxious, maybe they're, feeling like their sleep isn't as good, they struggle to fall asleep. There are a lot of women that express these things. I think that can be very beneficial. So we know, based on some of the research that I was looking at that she has conducted, that oral progesterone at a dose of 300 milligrams, this is a little bit higher than what I typically see. I typically see a range of 100 to 200 milligrams at night, increases deep sleep by 15%. Now, that's quite significant, because deep sleep is something that starts to become more challenging as we're getting older. Deep sleep is when we consolidate memories. It's when the glymphatic system, which is this brain detoxification system, that's when that is activated. And so as we get older, it is very common to see deep sleep erode. So very, very significant. I think the research that she was doing was looking at 300 milligrams, which again is a little bit more than what I typically see. But at that dose, a 15% increase in deep sleep, I think that's quite significant. These luteal phase defects, which is, the lack of progesterone, which exacerbates all of these symptoms that you're referring to. Now, one of the questions that came in multiple times was, how do I know when I'm ready to start bioidentical hormones? My doctors are not open, so I don't know who to go to. Thank you. That question is asked so frequently. I could add 10 names to that question, but many women feel like they are struggling to find providers that will actually address with bioidentical hormones, and not waiting until they go into menopause, because we know the research suggests starting bioidenticals when you're younger can actually be very helpful for alleviating a lot of the symptoms that women experience in perimenopause.
Yeah, and it's a really good question. And the answer is so individual. So teach my approach to that answer. And so if a patient comes in, whatever the situation, I do my foundations first. I want them to do the Keto Green 16 recipes in my book, Keto Green 16, because it's the shortest, quickest, easiest, and they're excellent medicinal recipes. I want them to work with intermittent fasting, follow that, and I support them with the adaptogens. For me, it's my formula Mighty Maca Plus, adaptogenic. Through the years, we've shown an increase in day 21 progesterone within 2 months. And so it helps support your body's natural hormonal production as well as detoxification and elimination. It's very alkalinizing. And I have clients check their urine pH. I mean, I want them to do this first because it takes more than hormones to fix our hormones. And take it from me, like that it was able to extend my menopause from till age 56 because of these practices and principles, versus my early diagnosis of menopause initially at age 39 and full-blown perimenopause at 48. I had to learn to shift things in order to preserve ovarian function and adrenal function. So then it's like if I like to clean up, you've got to clean up the terrain, so to speak. So detoxification becomes key. What could be causing the hormonal insufficiency and the imbalance to begin with? Is it cortisol? Is it insulin resistance? Is it hormone disruptors? Is it, there's something genetic with methylation defect, or, it could be anything. And so a sulfation defect, especially anything that can affect our P450 enzymes in our liver. So we want to clean that up, right? Just like you send a car in to get an oil change, we want to do a good filtering. And because it's going to have to process our hormones, and we want to, if we're replacing hormone, replenishing, I like to say I replenish hormones, not replace them. If we're replenishing hormones, then we want to do it safely, so your body's metabolizing them well. And that also comes in why the medicinal menus are so important, and fixing the gut, healing the gut is critical to hormone balance because of our estrobolome, and it's also critical for longevity. So with that said, like, I want the foundations taken care of, and yet still client very symptomatic, I can say, look, I'm going to start you on these hormone, I'd like to start you on these hormones now. We may be able to wean off them, especially that perimenopause time period. So, but I'd rather, like, within 16 days, we see an 80 to 90% improvement in symptoms, and we can retest and see where do we need to supplement. So then, the adaptogens come in. I start with my progesterone and pregnenolone combination first. That's my balance cream, because those are the mother hormones. And from there, we'll support our steroid hormones, our sex hormones, DHEA, testosterone, and estrogen. So we'll support those top down that way. And that's the first hormone, statistically from age 35 to 55, we lose 75% of our progesterone. So why wouldn't we be replacing it? In contrast, we lose 50% of our estrogen during that time. So then when do we add in estrogen? Again, we can talk about this a lot, Cynthia. I'm going off on a tangent, but I usually start with progesterone, pregnenolone. I start with adaptogens, cleaning up and detoxing, and then progesterone and pregnenolone, usually cyclically in the perimenopause, and then continuously, with the exception of 1 day off a week or 3 to 5 days off per month in the postmenopause, and then DHEA, and then testosterone and estrogen.
I think that one thing that this really reaffirms is how critically important lifestyle is, because how many women listening maybe got started on replenishing their hormones, let's find that reframe, and they then find that they start gaining weight. And likely because the foundational elements had not been addressed. And I do think the alkaline diet is really very, very important, really encouraging us to eat nutrient-dense vegetables and to be conscientious about how we're choosing to eat. Questions also about HRT. How do you know when to increase estrogen versus progesterone dosing? Are there specific symptoms that you are looking for? I know that's nuanced.
Yeah, it's very new. And again, like, first thing that comes to mind, I'd like to take a look at your genetics, right? Because some people can't tolerate progesterone very well, and especially oral progesterone. Also, if you're in a high stress state, is shunting directly to cortisol, and you're going to start gaining weight, and you will know right away that this is not working for you. And so there's ways we manipulate. Transdermally, certainly the pregnenolone with progesterone has a nice, even, distribution and half-life. So that, we have to look at that. And as far as your symptoms, one thing is, I do lab testing, right? I like to test clients' labs, but depending on how you're getting the hormones, whether it's oral, transdermal, troche, vaginal, injection, pellet, et cetera, it's going to depend on how we look at that. And is it going to be blood work? Is it going to be urine? Is it going to be salivary? What are we going to look at? But so with that said, I would typically look at initially when I evaluate my clients, I look at initial blood works. I look at total estrogens and estradiol level. I look at free and total testosterone, DHEA sulfate. And you've got to look at the thyroid. You've got to look at other markers. I look at other markers for longevity in my routine labs. And then, I typically will follow up with a Dutch test because I've been doing this 30 years. I'm a good clinician, solid, right? And I always teach my physicians that I'm training, treat the patient, not the labs. Ultimately, you have to treat the patient and not the labs. There is such bioindividuality to how we need it. So for, if I'm deciding to use a low dose estrogen patch on you to start, I'm also going to counsel you, look, you may need more, you may need less. We're going to see how you do with this. And then also we're going to watch your estrogen detoxification pathways. And the same with progesterone. For myself and for many of my clients, we do oral progesterone at night, taking a few breaks, oral progesterone at night, and use the balance cream, the progesterone with pregnenolone, during the day. My mind is just better that way. And, I notice, it has those benefits. So we've got that covered. So I'm not for other clients, I have another physician client, and she's on 400 milligrams of oral progesterone, always only bioidentical at night. And so, that's a heavy dose for me. I need 100, and I use the cream. So I get a 24-hour distribution versus, a 16-hour with just the oral progesterones.
Hey, if you like this video, you guys are going to love this video, and I'll see you there.
We make almost all of our fat cells during childhood and puberty. And then once we finish puberty, we're done. That number of fat cells, in most people, there are some people who are an exception to this, and that's about 15% of people who are in the obese category. But most people reach a limit, and that's their fat cell number essentially for adulthood.